All right, so this is a continuation, the second part of Chapter 7a on the axial skeleton, um, with discussion of now joints in the axial skeleton. We're not talking about the skull just yet, that we'll save that for Module 3. So we start with our inverse relationship between the mobility and stability of joints, and you can see across from left to right that there's a high degree of mobility in the glenohumeral joint, which is the shoulder joint, as we talked about with the ability of the scapula to move, as well as that glenohumeral joint. There's quite a large amount of range of motion possible at that joint. And then as we move across the screen, we see a decrease in the mobility possible at a joint from the coxal hip or coxal joint to the elbow, intervertebral joints, which are, remember, amphiarthroses, to sutures, which are synarthroses. And as that mobility decreases, the stability of joints increases. So the sutures being the most stable joints that we have. And to make up for this lack of stability in the glenohumeral joint, the joint is supported in large part by ligaments and also tendons that we'll talk about. All right. Whoops. Okay, so here's our first joint here, the atlantoaxial joint, which is between the atlas here and the axis. We talked about the parts of these joints here. You can see that the dens, or the odontoid process of the axis, is sort of held in place by this ligament here across the anterior arch of the atlas. So what happens here is, if you can picture the skull kind of sitting on the top here, when we shake our head no, the atlas sort of pivots around the dens of the axis. So that's a synovial pivot joint. And as a synovial, that's how we would structurally classify it. And as a pivot joint, it's just movement in one plane, so we'd call it a uniaxial joint. And any synovial joint that we talk about is also considered a diarthrosis if we were to talk about the functional classification of the joint. And so now we look at the skull, and the point here where the skull articulates with the atlas is referred to as the atlanto-occipital joint. So these structures here are occipital condyles, part of the occipital bone of the skull, and they are convex rather. And if we look back at the superior articular surfaces of the atlas, you can see that they should be here concave. All right, so that creates a joint here where you can nod your head yes, which means you're flexing and extending that atlanto-occipital joint, or you can laterally flex the head at that joint. And if we can flex and extend, and that lateral flexion is kind of like abduction and adduction, and that tells you how to classify it structurally, which would be a synovial condyloid joint, or condylar. All right, so now we look at intervertebral joints, which are also called zygapophyseal joints. And those are these joints we talked about between the superior and inferior articular processes where the facets come together. And those are also synovial joints, but they're planar joints, so there's some degree of gliding motion between them. And if we look at the small degree of movement, this gliding movement between one articulation times all of the different zygapophyseal joints along the whole length of the vertebral column allows you to laterally flex the vertebral column, say in the thoracic region, or to flex and extend the vertebral column in the lumbar region, depending on, again, the plane of articulation of these intervertebral joints. Now the intervertebral discs are shown here between the bodies, and that's a layer of fibrocartilage. We'll talk about the structure of the disc in a little more detail here in a second. But it's made up of fibrocartilage. So we would refer to this as structurally as a cartilaginous symphysis joint. And you might think back to, in Module 1, we had another cartilaginous symphysis, which was between the two bodies of the pubic bone, called the symphysis pubis. So same idea here. There's a mild degree of movement, so we could functionally classify it as a amphiarthrosis, and that's characteristic of a joint that has fibrocartilage, as opposed to one that has hyaline cartilage as the the structure that holds two bones together. All right, here is a diagram of a herniated disc, and we can see more of the structure of the disc, where the annulus fibrosus is primarily that fibrocartilage here on the exterior of the disc, and then in the interior is a more fluid-like substance called the nucleus pulposus. So if you recall, fibrocartilage helps with resisting compression and absorbing shock, which was very important in the vertebral column. Now, when the nucleus pulposus pushes out through the annulus fibrosus, it can actually put pressure on the spinal cord or on one of these roots or even the spinal nerve itself and result in some symptoms, whether it's pain or numbness in the limbs relative to where that herniated disc is occurring. So if it's up in the cervical region, we might feel numbness or pain in the arm. If it's down in the lumbar region, perhaps feel it down in the legs. All right. Now there are three. This is information we did not talk about in the lecture here. There are three main spinal curvature deformities that we can discuss: kyphosis, lordosis, and scoliosis. So we'll look at the diagrams here. Kyphosis is where there's an exaggerated anteriorly concave curvature, and most often it's seen in the thoracic region. So it looks like a humpback. And the cause of this is maybe several reasons, but an example of a cause would be in women who have osteoporosis, where the vertebral bodies are starting to lose their bone density and become much thinner. And so when they do that, then they create sort of a more exaggerated thoracic curvature or kyphosis. Another cause would be lifting heavy weights during adolescence or as the result of an injury. A lordosis, you can see here, is an exaggerated anteriorly convex curvature and most often seen in the lumbar region. So we usually associate lordosis with the lumbar curvature. So this results in this curvature results from obesity or pregnancy or some reasons for this, where the abdomen protrudes forward, and to balance that weight, the buttocks kind of protrudes backwards in the posterior direction. Scoliosis is the most common abnormal curvature and is the result commonly in adolescent women or adolescent girls, where the vertebral bodies or vertebral arches are not developing at the same rate on the different sides, right versus left. It may also be the result of a deformity, and it most often occurs in the thoracic region. So you can see that thoracic region is where we're looking at that curvature. So there are other causes that you might read about as well. All right, so now we move into the thoracic cage, and we're looking at the region that protects the vital organs in the thoracic region, such as the heart and lungs. It consists of the thoracic vertebrae posteriorly, and the ribs laterally and anteriorly, and the sternum also anteriorly. And there are a lot of muscles that we're going to talk about that move the upper limb that are attached in the thoracic region. All right, so we'll talk about these kinds of ribs that are part of the thoracic region here. Looking here, there's the sternum divided into manubrium and body with the xiphoid process extending inferiorly. The manubrium has a notch superiorly called the suprasternal notch or the jugular notch, and just adjacent to that are the clavicular notches, where we would find the sternal ends of the clavicles articulating there. Now we're looking at ribs here, and there are 12 pairs of ribs. So we're looking at the numbers here on the left, and you can see the first 7 ribs have costal cartilage that attaches directly to the sternum. So those are called true ribs. Ribs 8, 9, and 10 have costal cartilage here, you can see, but instead of attaching directly to the sternum, they attach to the costal cartilage of rib 7. So they are considered false ribs. We have 2 more false ribs, rib pairs number 11 and 12, but interestingly, those are also referred to as floating ribs because they have no costal cartilage that attaches it to the sternum. Now, it's important to know the type of cartilage that we're looking at here in the costal cartilage. This would be hyaline cartilage. And so that's going to have an impact on how we classify the joints that we're looking at here between the ribs and the costal cartilage, as well as at least up here between the costal cartilage and sternum. All right, so we'll look at the next image here on articulation. So if you'll recall in chapter 9, the articulation between the rib and the costal cartilage is a cartilaginous joint that is, because this is a hyaline cartilage, is going to be called a synchondrosis. So a cartilaginous synchondrosis for the costochondral joint. This is the anatomical name of that joint, is the costochondral joint, between the costal cartilage and rib pair 1, the costal cartilage and rib pair 2, and so forth. So the costochondral joint is structurally classified as a cartilaginous synchondrosis, as is the first sternocostal joint. So the anatomical name of this joint between the costal cartilage and the sternum is called the sternocostal joint. We would structurally classify it as also a cartilaginous synchondrosis. And if you remember that if a cartilaginous joint is made up of hyaline cartilage, it's functionally classified not as an amphiarthrosis like the symphysis, but rather as a synarthrosis, meaning not movable in any way. All right, then if we look, so that's just for the first sternocostal joint. For sternocostal joints 2 through 7, it's a little bit different. These happen to be synovial planar joints. So sternocostal joints numbers 2 through 7 are synovial planar joints, and that has to do with being able to allow the ribs to elevate during respiration. So those synovial, these synovial joints here, sternocostal joints 2 through 7, because they're synovial, we would classify them functionally as diarthrosis. All right, now that brings us to the ribs. The ribs are attached to both the, as we already saw, the sternum. So here's the end of the rib that articulates, attaches to the, or articulates with the costal cartilage, forming that costochondral joint. But we're going to take a look back here at the posterior end of the rib where the head of the rib is. So here's the head of the rib. The constricted region lateral to the head is the neck, and then we have a tubercle of the rib. All right, so both the head and the tubercle have articular facets that allow it to articulate with vertebrae. All right, so we refer to both of those joints, the anatomical name being the vertebrocostal joints. And so the head of the rib, the vertebrocostal joint that occurs at the head of the rib, is going to articulate with the vertebra on these costal demifacets, which we saw on a vertebra, a thoracic vertebra. And the tubercle of the rib articulates with the costal facet, the full facet, that's located on the transverse processes of the vertebrae. Both, again, have the anatomical name vertebrocostal joints, and both are structurally classified as synovial planar joints once again, so functionally classified as diarthroses. Here's that, to illustrate the articulation. The head of the rib would articulate with the costal demifacets between two adjacent vertebrae in the thoracic region, and the tubercle of the rib articulates with the costal facet located on the transverse processes of thoracic vertebrae. So make sure you know what the articulating components are on the rib relative to the vertebra to form the vertebrocostal joints. So that concludes the second part of this chapter 7a, and we'll continue with the next video that is on a combined material from chapter 8 and 9 for the upper limb on the bones of the appendicular skeleton, upper limb, and also the articulations of the upper limb.